picture where I'm showing I was in a hardware NVENC on recording. When I wanted to record, it did not allow me. So from this hardware encoder, that is NVENC, right? I changed it to this one, software X264. Once I'm done, just do this, click apply and click OK. So this will clear that error and it will allow you to go ahead and do the recording. So I hope this video helped you, right? Like I always say, if this helped, give us a thumbs up, give us a like.
5 years from now, I'd like to see NTTCHP
talking about health in the robotics age.
A full undergraduate course.
known globally and internationally.
Full running PhD program by then.
Magkaroon na rin kami ng sariling building.
These things may not be here yet, but one thing is for sure. Dreams are big in the National Teacher Training Center for the Health Professions. As the second youngest college in the University of the Philippines, Manila, NTTCHP is geared towards expansion and growth, creating huge waves of innovation in the field of health science education in the coming years.
NTTCHP is one of 9 degree granting units of the University of the Philippines, Manila. As a graduate college, we equip health professionals to be effective facilitators of learning, educational planners, evaluators, researchers, managers, and leaders through our various programs. We analyze evidence, we generate knowledge, and from there advocate best practice in all educational settings for the advancement of health professions education.
As of the end of the first semester of 2019 to 2020, the college has produced 95 BCH PED, 101 DH PED, and 189 MH PED graduates who have been appointed to key and strategic positions to contribute to transformative education of health professionals. NTTCHP not only creates impact in Manila, but also in different parts of the world through their international partners, namely Thai Binh Medical University, Hanoi, Vietnam, the University of Health Sciences, Lao People's Democratic Republic, and the University of Health Sciences, Kingdom of Cambodia. From among the mentioned alumni, 16 are DH PED and 12 are MH PED alumni from the Kingdom of Cambodia through a collaboration program with the World Health Organization Western Pacific Regional Office and the French Cooperation.
When teaching and learning in the health sciences first came out in 2010, everybody was quite excited because it was the first textbook from the Philippines in health professions education. It won the most outstanding book awarded by the National Academy of Science and Technology in 2011 by Dr. Badner and I. It was a thought-provoking book that made the concepts of teaching and learning simple.
The National Teacher Training Center for the Health Sciences was founded in January 30, 1975. During the University of the Philippines Board of Regents' 857th meeting, the center, headed by its founding director, Dr. Corazon P. Gonzalez, was under the Dean of the UP College of Medicine, Dr. Florentino B. Herrera Jr. In its 899th meeting, held on March 13, 1978, the UP Board of Regents changed the name of NTTC to the National Teacher Training Center for the Health Professions, or NTTCHP. UP Manila was then declared by the UP Board of Regents as an autonomous unit in the Health Science Campus in 1979.
NTTCHP was founded during the Decada 70 or the first 10 years of martial law. Despite of all the challenges of the 70s, we were able to develop more or less a robust training program for faculty development that eventually resulted to strengthening of the way we teach health professions education.
NTTCHP was originally a part of the master plan of the World Health Organization or WHO's network of teacher training centers. In 1971, Dr. Corazon P. Gonzalez, then a full-time faculty member of the UP College of Medicine Department of Physiology, was sent to train to the Regional Teacher Training Center in Sydney, Australia. After her training, the WHO was convinced that there's a future of an NTTC based in the University of the Philippines, Manila. WHO noted the strong and positive response of UP Manila to health professions education. May 28, 1981, the UP Board of Regents approved the offering of the MHP Ed degree program. With this degree program, the NTTC ceased to become a mere service unit and became a degree-granting college of UP Manila.
So in the school year of 2001-2002, the master's degree program in health professions education was developed into a ladderized curriculum. Ladderizing the program allows the students to exit at any point, ending up with a certificate, a diploma, or a master's degree.
responding to the challenges of the 21st century and in synchrony with the policy standards, the mandate of the University of the Philippines, and the guidelines for graduate education program of the Commission on Higher Education. The college now offers the Master in Health Professions Education or MHPED professional track, consisting of 30 units of coursework, and the Master of Arts in Health Professions Education or MAPED, which is the academic track composed of 24 units of coursework plus 6-unit theses, totaling 30 units. The two master's degree programs include new core and elective courses and reconfigured courses from the ladderized program and capstone project or portfolio. Furthermore, the new DRH-PED professional track program is open to all master's degree holders interested to pursue a career track in advanced HPED fields. It is composed of 26 units of coursework and 12 units of dissertation. Finishers of this program are expected to 1. Pursue careers as health professions education scientists who conduct independent research and contribute new knowledge, methodologies, and technologies. 2. Educational leaders and managers who can address the challenges of the 21st century higher education institutions. And 3. Agents of transformative learning.
NTTC HP's curriculum is offered in both residential and off-campus platforms. It was first offered in off-campus mode in Cebu Institute of Medicine from 2004 to 2008, then in the Kingdom of Cambodia from 2012 to 2015. At that time, NTTC HP was recognized as one of two of WHO's Regional Education Development Center in the Health Professions Education in the Western Pacific region. In 2015, NTTC HP's curriculum was again offered as off-campus mode in Cebu Institute of Medicine and Southwestern University, FINMA.
The National Teacher Training Center for the Health Professions is proud to have 7 heads of units from its foundation. They are the ones who greatly shaped the college over the years and give it its deserving prestige and platform. From 1 full-time and 2 part-time faculty members, NTTCHP now has an impressive lineup of professors. The research extension and professional staff of NTTCHP is also composed of 2 researchers and 2 library personnel. And there are 6 administrative staff. After 45 years, and true to the original World Health Organization mandate, NTTCHP, through its alumni from different institutions, paved the way for the creation of 8 medical education units, namely UP College of Medicine, the University of Santo Tomas Faculty of Medicine and Surgery, the University of the East Ramon Magsaysay Memorial Medical Center, and Manila Central University in the National Capital Region, De La Salle Medical and Health Sciences Institutes in Luzon, Cebu Institute of Medicine, and the West Visayas State University College of Medicine in the Visayas and Davao Medical School Foundation, College of Medicine in Mindanao. In 2012, the Educational Development Centers for the Health Professions were also founded in the University of Health Sciences, Kingdom of Cambodia, and Lao People's Democratic Republic. The 21st century brings new and emerging roles for the present health professions educators. NTTCHP responds by offering its revised outcome-based and blended learning postgraduate curriculum in 2020. The college will continue to offer relevant programs, conduct research and extension services that meet the challenges and gaps of the time in the Philippines and in the Western Pacific region. With all these trusts and accomplishments, NTTCHP hopes to be recognized as a national center for excellence for teacher education and the World Health Organization's collaborating center in health professions education.
Good afternoon, everyone, and welcome to our monthly seminar. Before we begin, we would like to share with you some of our house rules. So, let us be reminded that we are requested to mute our microphones and turn off our videos all throughout the presentation. However, if your connectivity allows, I think our speaker would appreciate that some of us will be seen moving in our videos or cameras. Then you can type your questions in the chat box if you have any questions. And then please do not record, by the way, or take pictures of the slides without the permission of our resource person. And the Q&A will follow after the presentation. And please do not forget to accomplish the client satisfaction survey so that you can have your copy of your e-certificate. So make sure also that the name that you would like to appear on your certificate are the names that you have written in your registration. Okay, so once again, good afternoon. I am Emily D. Bicolen, an Associate Professor of the National Teacher Training Center for the Health Professions. And with me is our Administrative Assistant, Ms. Divine Maling, and we will be your moderators or MCs this afternoon. So we would like to thank all of you for attending our 6th monthly seminar and the last for this year. We have right now 200 participants in our Zoom, and some participants are also in our YouTube live stream. Towards the end of the seminar, as mentioned earlier, now we will give you the link to our short client satisfaction survey that we hope you will fill out. And then upon completion of the survey, your certificate of attendance will be emailed to you. You may use this when applying for CPD units for self-directed learning activity. Now, before we call on our speaker, it is our pleasure to share with you the evaluation results of the previous monthly seminar on giving feedback. So, ladies and gentlemen, let's welcome Ms. Claire Pastor and TTCHP's reps to share with us the results.
Good afternoon, everyone. Okay, welcome to the monthly seminar of NTTC. So before we continue, as what Dr. Decolen said, that we'll share with you every after of the seminar, we give the client satisfaction survey. So we are sharing with you now the results of the previous. This is the art of giving feedback, last September 26, with Dr. Decolen as our speaker. So in the survey, the results in the survey, we have questions on the assessment, on how they assess the event, with a rating scale of 4 being strongly agree, and and 3 disagree, and 2 disagree, 1 strongly disagree, and A for not applicable. The participants, we have 354 participants from both the YouTube and the Zoom for last September, but only 271 accomplished the CSS form. So with they find with the criteria that we have, with the event was well organized, the average that were given is almost on the strongly agree, as well as with the objectives and the purpose were clear for them. And also they said that the event met their expectations with an average of 3.86. The information presented was relevant and useful with a 3.92. The speaker was very effective, 3.91, as well as the visual aids used with 3.84, and the virtual platform they find is safe and secure with 3.87. There is also a question on how they assess their self-assessment when it comes to their level of knowledge and skills. So before the training, mostly of our participants were in they meet the expectation, but right after the training, we are happy to say that most of them are on the outstanding. Their self-assessment on level of knowledge and skills now on the outstanding. And also for the overall assessment of the activity, when it comes to the effectiveness of the activity in meeting their personal objectives, they find it also outstanding with 4.80, the timeliness of the activity with 4.70, and the overall quality of the service that provided with 4.81. We also asked for for the comments and suggestions with the three questions. So what did you like best with the seminar? So there's a lot of answers, but to give you a few of their answers are the speaker is excellent, very charismatic, lovely, sweet, and talks from the heart. All topics are very informative, comprehensive, and interactive. A lot of them said it is everything. They love everything and the small group discussions. And for the what did you like least? So this is for the improvement. This is the top five. They find it too long, but others are requesting for longer hours. So the audio daw po is sometimes gargled or choppy from their end also, and for the at end of the organizing committee. The internet connectivity on their end and the connection glitches, and also for the limited Zoom participants. With this po, that's why we have the YouTube platform kasi po we only have, sorry, the 300 capacity in our Zoom account. And for the topics for future trainings, these are the top five. They are requesting for mental health awareness or stress management, how to give online examinations, teaching and assessment strategies, the planning syllabus and the lesson plan, and also the qualitative research. So we really at NTTC po, we really value your comments and feedback. This is how we improve the services that we have. So we request everybody to accomplish the client satisfaction survey to be given po after the event. So thank you very much. Back to you, Ma'am M.
Thank you, Claire. And right now, there are 233 participants on Zoom, and we would like to acknowledge the presence of our colleagues from Cambodia. We have participants now from Cambodia. Okay, so our theme for this year is authentic assessment. Dr. Melflor A. Atienza discussed the assessment of clinical skills in July. And in September, I shared practical tips on giving and receiving feedback. This time around, we will discuss a specific topic that we need in doing authentic assessment. To talk about assessing the primary care health professions educator is Dr. Leilani A. Nicodemus, the director of the Center for Gender and Women's Studies of the University of the Philippines, Manila, and a professor of the College of Medicine of UP Manila. Our speaker is a multi-awarded practitioner, and the most recent of which is the 2020 Human Resources for Health Recognition Award, given by the Asia Pacific Action Alliance for Human Resources for Health. She belongs to the pioneer cohort of our Doctor in Health Professions Education program at NTTCHP. Ladies and gentlemen, let us give our speaker, Dr. Leilani Nicodemus, a virtual round of applause.
Thank you, Emeline. I'm so pressured. Good afternoon, everyone. I have to give my disclosure because the topic given to me is something I never thought of developing. So I never read about it, even if I've been involved in primary care training for the longest time. And I said it is like doing thesis already. Anyway, so I'm so happy that people are interested, and I'm also glad that there are people in the audience who are already involved in primary care. I saw familiar names and colleagues in teaching primary care physicians in the government sector. Okay, so the topic is about assessing primary care health professions education, and it's actually linked with the theme of this year's overall theme of this year's monthly seminar. But knowing that I have poor handles because I don't know anything about assessing a primary care health professions educator because it's something new, I have deviated a little because that's me. I'm not a conformist. Okay, so these are my disclosures. So don't mind people with me in the camera. I just want to share with you that I might have biases in my sharing. So that's why during the probably in the Q&A, I would invite you to share also your experience so that it will not be doctor centric, because I am a doctor and I train primary care physicians. So I advocated for the definition of primary care, because if, this is anyway a democratic country. So I can say that if we leave laws to non-medical politicians, then you will have trouble in defining and identifying the essence of the law, especially on primary care. So I deep dive and have been involved in the discussions with senators. And then I was involved, as I mentioned, with fit for purpose training for primary care physicians in the government sector. And nilagay ko lang dyan si Senator Chis Escudero. It's a joke between us that I would help him if I would see his wife. Unfortunately, I wasn't able to see his wife. Okay, so my disclosure is I might have some biases, but be mindful of that and probably engage in discussion in the Q&A. All right, so the outline of my presentation, I would like to have common terms. You and me would understand the key terms that we use in the parlance of primary care, because most often in the discussions and even in the presentations, there are terms mistaken to be the same, but it's not. And then second is to discuss the features of primary care and why do we need to belabor with understanding the HRH competency development and why do we need to look into the Philippine context? It's easy to copy probably UK's version of primary care, even Australia or Canada, because they have a very good experience. They've been doing primary care in the longest time. But we have to understand what is very particular or peculiar in the Philippine context. And then lastly, it says assessment, but I would like to offer based on the scoping of literatures, because you can't even find any article that would really look into effectiveness of faculty or teachers or trainers in primary care. So I would rather talk about attributes and leave probably how you would assess in your context based on your comfort, because you already have enough discussion of this in the previous seminars. So let us start with the first, primary care versus primary health care. People are always saying, it's just the same. I beg to disagree. It is not the same. Okay? Primary care is the provision of services so that you make these services accessible. And these services should respond to majority of the health needs of the people. And since primary care would be the care that these people would need in their lifetime, then there should be partnership. And therefore, it is connected with family and community. So this definition has been there since 1996 by the Institute of Medicine Committee, when in the United States, they they wanted to craft what is really primary care in our own context. But if you look at the definition, I think it's also applicable to us. So there are features integrated and accessible, and the services provided would be primary care clinicians or practitioners. in our own context, we would say that the primary care providers are anyone who would be engaged in providing care in primary care. So it can be physician, it can be nurse practitioners, or other health workers. But what is very particular in this type of definition that we would also want, that our country would embrace, is the creation of primary care team. And I will always say that nobody owns or be superior in primary care, because the team should be able to deliver that kind of integrated and accessible health services for the people. So there is so much that is being asked in terms of accountability to the practitioners in terms of provision of quality of care. There should be a conscious effort to provide patient satisfaction, use of resources efficiently, especially in our country. We are low resource country, and you know that the out-of-pocket payment right now is about 58%. So we have to make use of our resources equitable so that those who cannot pay would also have to receive the best care that they deserve. And as I've mentioned, the care should be addressing most of the needs of the people in terms of physical, mental, emotional, and social concerns. So it is not limited on health, but the whole persona of that patient. And as mentioned, a sustained partnership, because if you don't have any sustained partnership, your patients or your people would seek consult to other health facilities. So you will not be efficient in providing care. You will be spending more resources if patients would not be happy in the partnership. And then there should always be understanding of the context, because that makes our primary care different from other countries. Primary healthcare, on the other hand, is an approach. It's an umbrella perspective that aims to make health care, or that makes primary care equitable to all. So that's where Health for All emanated. And you have heard this in the Declaration of Alma Ata. And there is reaffirmation in the Astana Declaration. And I assure you, Astana is not perfect. It is, there are some parts that is problematic, but there are parts that we can use in terms of understanding primary health care. So there is an articulation that there should be continuum. So primary health care is an approach that would encourage all members of the society, not only health, to be participants in making sure that health is being provided. So because of that approach, so therefore, primary care services should be where the people live. So there are a lot of discussions here. We've been in several fora, and people are asserting that outpatient in an hospital is primary care. Now, if you use primary health care as a context or as an approach, it is not. It is not. Because hospitals, as you know it, are in the urban or in an area, in cities, or probably not in the remote rural area. So that's why we have a lot of countrymen not able to access services. So it's a counter to the concept of primary health care. Okay, so as I've mentioned, integrated, it should be responsive to the health needs, multisectoral, not only health, but also on education, because it encourages social development. If you would have a good collaboration with other sectors of the society, then the provision of care would be easy. Because, as I would stress later on, the context that we always say is that health is determined by uh, social issues. So you call that social determinants of health. Right. So, and then primary health care will not only be about giving health services, but enabling individuals get the optimum care. It's linked actually with the right of the individual to have quality health services. So health is a right. So all this approach, perspective is within primary health care. So I hope if we talk about primary care, it's different from primary health care. But you can say, but they're almost the same. Yes, because primary care is a strategy for primary health care. All right. So this presentation of the relationship of primary care and primary health care can be seen in this graph. Now, primary care, as I have defined, is provision of services to the need of the people. Look at this presentation of the needs of people. So if you look at the healthy population, it is mostly probably what we see in the communities. This is where you would now, if you go to communities, to houses, and you will be seeing healthy population. And that is the start of primary care. Taking care of the healthy population, because mostly, probably our population, but I doubt, probably in between, our population, they need health promotion. They need disease prevention and wellness program. We saw this during the pandemic. There's really manifestation that our primary care is so weak because the way we prevent COVID from transmission or be transmitted in the community, we have a very poor mechanism. That is because we never understood the strength of primary care in providing for the needs of the healthy population, right? And then moving forward, the population at risk. So this is probably those individuals coming from workplaces, from schools, doing screening tests. So we are considering them as possibly population at risk. So we do risk identification, screening, and early detection. Okay, so if you look at healthy population, population at risk, it is majority probably of our people. And sick population would just be a segment. So if you don't recognize primary care, then your sick population will get the whole chunk of this graph or this presentation. Okay, so that's how primary care is being crafted, and that in the law actually of universal health care, there's articulation of the spectrum of care. That is now what primary health care would say as continuum of care, so that there will be no progression of disease to disease complication. So there's promotive, preventive, until your supportive and palliative care for terminally ill cases. Okay, so this is how we use it in our context as family physicians. I'm not sure if you have the same constructions in your health profession, but it's a very nice presentation of showing that majority of our population belong to healthy and population at risk that we don't give so much attention to. Okay, so the RA 1122-3 Universal Healthcare Law was signed in 2019. I cannot avoid to discuss this because this Universal Healthcare Law tried to enshrine primary health care. Okay, people would say it's imperfect and it's very selective. I agree. But it is something that would help us lay the foundation for a primary health care approach that would encourage multisectoral collaboration. So this UHC articulated this kind of healthcare model, somehow trying to put in concept or perspective of primary health care because it says provides all Filipinos access. So there's an attempt for health for all. And that kind of care, which is primary care, is comprehensive set of quality, cost-effective, promotive, preventive, curative, rehabilitative, and palliative health services. Okay, the financial hardship and prioritizes the needs of the population who cannot afford such services is an attempt actually of overcoming the ills of our health system, that those who cannot afford should be able to receive the same quality of care. And if you look at how it is being defined, probably you would say it's the same with the WHO and how other countries embraced also in terms of their universal health care. But for low-resource countries like us, this is something that we can offer our people because it's a services that would give them or provide health care for their needs. Okay, so what is the implication of these concepts in education and training? So in the past, we've been just discussing about health. Now there's introduction of universal health care. And the universal health care really has a very good intention because it will ensure somehow health for all. It may not be in terms of equity, because there are a lot of questions about that, but there's an attempt to make health services equitable. So in the law, that is where there's already an articulation of multisectoral collaboration in terms of health professions development. So there are provisions there. So the first one, I think you know this, you felt this, different colleges or even universities are trying to reorient their curriculum so that there is, mind you, read this, primary health care, emphasis on the combination of public health and primary care. So there is really an intention of telling us that when we reorient our curriculum, it should be in the approach of primary health care. Okay, and primary care is a component of your primary health care. All right, but what is very interesting is that there would be recommended areas of studies in public health. So this is puzzling because there are people who are, what kind of public health content should we introduce in our curricula? So I'll share to you the CHED memo. It's a joint issue once, and probably think about, is this the only public health interventions or concepts that we can introduce in our health professions education. Okay, and the last would be educational outcome. And I want you to mind again that focusing these outcomes not only on education, but also on licensure exams, CPD, certification programs of health workers. So this would now change the landscape actually of health professions education. Now, the DOH trying to put out guidance because honestly, when we have embarked on training, we called it fit for purpose, but we cannot get any a template what we mean as fit for purpose. We just used articles from other countries and use our experience as a specialty that trained primary care physicians. So we just combined everything. So we call it fit for purpose. But eventually, DOH put forth this National Human Resource for Health Master Plan 2020 to 2040. So you can download the whole document and read it because there are a lot of interesting topics there, and you can actually use that as a lens in developing your own health professions education in terms of competencies and assessment. But what is emphasized in that master plan is the generation, appropriate generation, recruitment, retraining, regulation, retention, and reassessment. So I always say, are we ready really of doing all these things? We don't know the real number of practitioners, active practitioners in primary care. Even in medicine, we don't know who among our members are actively involved in primary care. So the generation until now is based on gut feel. Recruitment is something that there are a lot of administrative orders being issued already. Retraining, I think it goes with the reorientation. Regulation, there's already a provision for certification for primary care providers. And until 2022, there will be issuance of provisional certification. What does it mean? So the certification and regulation would come in. That means to say there will be assessment of competencies. If you have deficiencies, then you will have retraining. So that is the implication of the certification process that DOH is doing right now. Okay, and retention, this is something very hard. We've been involved in DTTB education, and not all of them actually are being retained in their area of assignments for several reasons. And then lastly, reassessment. We don't have that yet in terms of policies. So we have an attempt to look into reassessment, but it's difficult because in other countries, they do written exam. But what is being put forth by the DOH is a portfolio assessment. It's a work-based assessment. So reassessing competencies using portfolio is not yet explored in this country. We use it in our specialty, but the reason for doing that is to check the depth of the training of the resident. But in terms of quality, if they achieve certain competency, we haven't reached that point yet. But based on the administrative order, reassessment of competencies will be portfolio based. Okay, so based on the national master plan, the KRA2 is what is very important to us, and it relates to what we are talking about in the past minutes. So strengthening health education and regulation. So there's again an attempt to say that we will regulate the number of practitioners If there are so many specialists, then there will be regulation. So actually, the PRC started getting definitions of level LAM. It's a matrix that would determine the professional qualification of different cadre in terms of their possibly competencies. So, but there's no disclosure yet of how they would regulate, but they got it, and I think it will be used for regulation. All right, so if you look at KRA 2, based on that book, there is an attempt for intersectoral collaboration to harmonize policies and plans. So there's some spirit of primary care, primary health care. And it is based, these policies would be based on needs and production. Now, if you have heard the Espesyalista ng Bayan of DOH, it is actually a stopgap measure. I don't think it will be a permanent intervention to address the number or maldistribution of health professionals in lower levels of care, like secondary and primary care. Okay, regulatory, there's no discussions on this yet. There are some activities, but there are no discussions yet, except for the certification of primary care providers. But what is so obvious currently is the reorientation of health professions education. I'm sure you have been doing this in the past few months, I think because it relates to the joint issuance of the administrative order of CHED, PRC, and the Department of Health. But what you need to know is that there should be really harmonization. So everyone should be on board. If you have doubts about how things are done, it's good to be on board. Because if you're silent, then you will not contribute at all to the crafting of the policies. So it's okay to disagree, and it's okay also to agree. So I think that is what we need to do now. Okay, so going back to primary care, based on the joint administrative order for the reorientation of health professions education, that's the JAO 2021-001, there's a portion there. If you read the JAO, you would see there that primary health care, that would mean public health and personal care or population-based or individual-based. And you would look into these services. So if you look at the services, it is not enough. Okay? It is not enough. Mass intervention, community vaccination, it's actually what we have. They just made it in one organized, like Marie Kondo thing. Okay, so I think that is the initial attempt, but it will evolve. We believe that it will evolve because based on our discussions, that is how it was intended to become. And if you look at research, because mind you, this reorientation is not profession specific, not for doctors only, not for nurses only, but whole health professions education, including medical technologists, dentists, or other allied professionals, OTPT. So if you look at this, it's really very basic. And there are a lot of discussions about research and publication. People from UP would know this, that research is not for everyone. So there's discussion about, are we going to push for research and publication to all primary care providers? So that's why I would always say that you have to participate in the discussions. But on our end, what we want is really the disease surveillance and strengthening of the disaster risk reduction and management in health. Because that is our country is disaster prone. And if you look at the HPE, how many are training their students on disaster response? So it is something out there being offered voluntarily. If you have interest on disaster, then you go to that kind of training. But if you don't, you don't participate. But disaster is part of the Philippines. So I think it should be part of HPE education. HP education. All right. So I use this as one of the guiding principles of the fit for purpose that I have mentioned initially for government physicians. The IOM 2003, because this is a bridge, it's an attempt to bridge the quality of care needed in primary care to the training of HPE. So it's very nicely put, and I placed there that all health professionals should be educated to deliver patient-centered care as members of interdisciplinary team, emphasizing on evidence-based practice, quality improvement, approaches, and informatics. In the past, informatics is something that we shy away. But I think we have to develop this because we need it. Pandemic made us understand ICT. So I think we need to develop it. But this is the last, actually, even if IOM put forth this kind of a very nice representation of what is common to all HPEs, informatics was, I think, lacking in terms of their assessment. All right. So I would present to you the primary care worker competencies. Because if you look, may I just go back, please? If you look at this is common to all HPEs. And if you look at the definition, it's really anchored on the approach of primary health care. It is not complete because it lacks direction, but that's fine because it talks about competencies. Now, this is the competencies of primary care workers according to the Department of Health. There are 7, 5 of which would be individual based, and it relates actually to primary care. So I hope you got it. IOM would like to embrace primary health care, but they lack also some components because direction towards health equity is not there. Okay. But here it's very clear that it's really about primary care. Now, if you want to reorient your HPE and probably think of faculty development, you have to use this as a basis and add more, probably marry the IOM common competencies for HPE. All right. And I think this is linked with the certification for primary care workers for universal health care that was issued last July 2020. So there's a self-assessment tool that you have to undergo, and that would determine if you fit or if you lack competencies. And if you lack competencies, then there should be retraining. Okay, the retraining, where do you get it? It depends on your HPE. I don't know. I think there's a progress now. There's an attempt to combine all cadre, talk about the common competencies for the retraining. I think DOH is attempting to do that because they have this learning platform. But competencies should not end with knowledge. It should also translate to skills. So I don't know how retraining would be done if skills improvement is attempted. Okay, so I'll share with you. So this is my bias, just a full disclosure. So in attempting to understand, because we were given a task in 2013 during the time of President Aquino for the Kalusugang Pangkalahatan, not yet UHC, but the idea is there. Tagalog lang, okay? Health for All, so KP. So we were requested to look into capacity building of government physician engaging in primary care practice. Okay, so we use this as a lens, this professional roles. And then we polish it when the universal healthcare came about. Okay, so we have, this is just an example just to show you the attempt to integrate the primary healthcare and the primary care together. So as a healthcare provider, we said, it should be a skilled generalist because we are family physicians, but the skill should not be limited to a particular population group or particular setting because we want to be more responsive to at least most of the needs of the people. And that within our practice, there is a conscious effort to adhere to ethical standards because in primary care, sometimes if there's no regulation, then there are practices not within the bounds of standards of care, right? So that's why we also included research, quality assurance activities to improve the healthcare. So if you look at healthcare provider professional role, it is self-regulating. And that is what we want to attempt in trying to define how primary care physicians or primary care family physicians should train. Okay. Now let's go to the coordinator. Coordinator is a professional role. It is also what is needed in the universal health care. And there is now an attempt to combine multidisciplinary and interprofessional teams. So we didn't call it primary care teams because we utilize the concept of multisectoral involvement and collaboration, right? So, and again, the purpose of that is to make sure that there is continuity of care, that the care that we provide is safe, and that the function of our primary care physicians would be within a practice network, what the universal healthcare is developing. Okay, so that's how we now put in the concepts of primary healthcare as the umbrella perspective, concept, and primary care as the type of care that we provide. Okay, so we have this as the core of our discipline. We crafted this as we tried to experiment what would be a good combination to describe and teach our trainees of what we mean by patient-centeredness, family-focused care, community-oriented care, trying to break down fragmentation of care, and also look at what we say about womb to tomb. So it's not easy. It didn't happen overnight, but the way we did it in terms of defining the primary care definition or the primary healthcare perspective in our context would be like this. Okay, so again, you might question, so where is now public health in your discipline? It's the context. We utilize the context of our patients, the families, and social determinants of health to help us understand them so that appropriate intervention, public health intervention, DOH programs can be used. So that's how we marry what the Department of Health, PRC, CHED is talking about, of trying to craft kind of primary care development putting in the essentials within a program. Okay, so this is now the meat of the discussion. Okay, so what is the health professions educator in primary care? So I tried to combine all what I read and also what is being provided for by the universal healthcare. Number one is role model. You have to walk the talk. If you would say, I will serve in the underserved, then go there. Don't stay in the hospital. When you say that primary care should be where the people are, then go there. So role model, the humanistic teaching attributes of an educator. Approachable, available, respectful and privacy because you have to model it. Beliefs of others, honesty, openness, and be responsible. If you say, I have to see my patients at this time, then be there. I think that is the humanistic, and that will now encourage young practitioners to stay. And that I think would help in terms of retention. Compassionate creates an organized, structured framework for patient care and culture sensitive. Role modeling. Second is competent interprofessional education. If you read the UHC, if you read the IRR, time and again, you will encounter network, practice network, collaboration, navigation, etc., interprofessional, multidisciplinary. So it's really being called to be taught to HPEs. We have to teach all our students, trainees, of how to engage with other health professionals for the patient. It's not about us as leaders, like physicians being leader of healthcare team. Excuse me, no, because that's not interprofessional. Leader would depend on the need. Okay, so if the need would call for a nurse to be a leader, then the nurse should lead the team. So that is acting with honesty and integrity, knowing your limitations. I am challenging everyone of thinking of tasks that you can transfer to other health professionals. For example, time and again, we are so sensitive for nurses to inject. Unfortunately, not all physicians are out there. There are more nurses who are out there. So the task shifting that have been done by other countries so that there would be appropriate skill mix and appropriate competencies in primary care would be met. We cannot flood primary care with all healthcare professionals. That is very inefficient, especially that there are a lot of remote areas in our country. And you know that, you give a program as a band-aid solution. So there should be a long term. So that's why health profession education is very important. So one attribute of an HP educator is knowledge in interprofessional education. Evidence-based practitioner. I've been practicing in primary care. Patients will come with several conditions, complaints, and sometimes you would sit and you cannot have a specific diagnosis. Imagine a very difficult, undifferentiated case. You can mess up with your diagnosis, you can mess up with your management. What if you're not reading at all updates on treatment? What is the safe management for particular condition? There are passe or the type of practice no longer accepted because it's not safe. So this is the bargain actually of research. I think research utilization would be the minimum. Well, that's based on my assumption, in understanding that all HPE should have common competency as an evidence-based practitioner. Somehow, there would be not generation probably because they are not into that, but utilization should be the must. And that all practitioners should adhere to patient safety and quality care. IOM separated quality of care as quality improvement. But based on our understanding of having a good evidence, and if you are an evidence-based practitioner, quality assurance is already incorporated in how you do things. Although it will not come overnight because it's a culture that you will remind yourself that you have to check yourself if you're adhering to guidelines. And how many patients have you treated properly? How many misses? How many wrong diagnoses, and accept your limitations? So it's really a change in behavior and a culture. So an educator who's teaching young, developing practitioners should show how to become evidence-based practitioner. Okay, leadership skills. Again, this is my bias. I just want to give you my bias because I like participative leadership style. And this is something that we also use in our department. The reason being is that it strengthens actually primary care teams and primary care networks because you tend to be transparent. Information is open from lower level of care up to the upper level of care if you have a network. And conversation is easy because people will not be scared of sharing that they miss something. And you can easily do remediation. Although the disadvantage is it will take some time to come up with decision. But the decision that the group will have as a team would be solid and it represents the sentiments of everyone. So there is ownership. So that's why we love participative leadership style in our training in primary care physician training for government physicians. You might hear bridging leadership. Bridging leadership is also good because you don't have the luxury of just having a so-so environment and nothing will happen. Alam niyo naman yung VUCA world. VUCA is a very volatile, unpredictable environment like what happened to COVID. So bridging leadership is also good on that. But you don't have to follow participative, but on my end, in advocating for team development, participative leadership style is good for my training. Okay, and then lastly, this is the last because it's good for us to discuss about your experiences at the end. Understanding what is primary care. So the primary care, if you look, this is based on WHO, it's a first contact care. So siguro, I would always ask people to open your minds. If you want your outpatient to be your primary care, then ask yourself, would that be the first contact of care? What if the patient would travel 1 hour to be in your OPD? Is that already primary care? Is that how you operationalize your primary care? Or would you want a clinic that can be attached to your OPD that is there in the community where your patients live? They don't have to travel 1 hour, spend so much money, or line up in the OPD for almost 10 hours, no, not 10 hours, 3 hours. So that is the essence. It's a first contact care. Comprehensiveness, because you have to look at the totality of that person, mental, physical, social, what else? Behavioral. Continuity of care, because you will advocate for your patient. We will always have to impress to our trainees that walang iwanan, because that's continuity of care. Patient-centeredness, because values of patients should always be considered in how we manage our patients. Family focus, because our resources, Filipino families really fight for their patients, especially if they're sick. So that potential to be the therapeutic ally is very good. And that will contextualize the primary care that we're talking about in this country. Community orientation. We love our community. So utilize community resources. Help patient navigate through available resources. So knowledge on this and translate in the way we teach our students is a very good attribute, because that is what we always have wanted through primary health care, where the shared principles of primary care, that is person and family centered, continuous, comprehensive, and equitable, hard to achieve. We just have to keep on doing it. Team-based and collaborative, coordinated and integrated, accessible, and high value. The last one, high value, people do not really put so much investment in primary care. So that's why there's a wrong impression about primary care. So I hope this time, when people byword is primary care, should really put high value and respect its potential to help most of the people of this country and reduce cost of care. So I think, in summary, primary care is care provision, while primary health care is an approach towards health for all, or equitable health services. Universal health care is just a health system that attempts to enshrine primary health care by strengthening primary care. So health professions education should reorient. Don't say that, nah, we've been doing that. No, you have to revisit. Use the lens of primary health care and ask yourself, would this curriculum support the implementation of the universal health care? Core competencies of HPs needs to be contextualized based on what we need. It's good to copy, but it may not be applicable to our context. Attributes of educators should produce a practice-ready cadre of health professionals that can follow contextualization of the health reform that we wanted. And that is for strong primary care. So if you ask me, how will I assess HPE educator? I gave you the attribute. There are different ways. Teaching effectiveness is just one. But probably, if you want to assess right now, you have to look at actual practice. Not rhetorics, but action. So, salamat po. Thank you. Over.
Thank you, Dr. Nicodemus, for this very clear and practical session. To our participants, you may raise your virtual hand so that we can recognize you. Or you may type your questions in the chat box and we will read your questions.
Maybe I'll ask them. Siguro put in the chat box if what is your current role now in your profession or in your area of practice. Are you an educator? And what are you doing in terms of reorienting your... Ang dami. Sige, what is your practice na lang? Dami kong tanong. type in the chat box your current practice. Are you an educator in HPE? Are you a trainee? Educator. Hi, Ruth. MedTech educator. So most of you are educator. I hope the others faculty, nurse. Wow. Thank you. I hope, yes. There are a lot of nurses coming, yes. Midwife. Okay, so thank you. I hope you read the IRR. That's the only way to understand the law and also understand what is primary care. And that's, I think, the reason why I stood my ground on some discussions, because there are things that I believe should be there in terms of our primary care. Wow, very good. Thank you for your responses.
Mr. Wendell Barawid raised his hand. Sir, yes, you can unmute your microphone, and if you would like to ask a question. Sir Wendell.
Let me read the question from Mr. Red Mangulabnan. I'm a FM training program consultant po. Salamat po ma'am sa self-reflective question. Does the training curriculum support the attainment of universal health? Maraming salamat ma'am.
Hi, Red. There's a question by Mila.
Another question po. What is your take on advanced nursing practice and its possible role in the implementation of UHC, especially in areas where there is no physician?
Mila, that's a very nice question. Actually, it's an issue not only with nurses, including physicians. For example, surgeons. What if there are no surgeons in a certain area? Would there be also training for those physicians serving in that area? It is something that we have to cross and understand policies, how to ensure that the task shifting that I've been mentioning should be based on the need. Because I think there are really areas where there are no physicians, no other healthcare providers except nurses, because we have a lot of nurses. Then they should be taught. But there was discussions about what if they leave that place? Would they still do it? And for example, they had the private practice. Now we learned our lesson from the Philippine College of Surgeons, and they're saying that you can only practice where you were given the certificate. For example, I'm serving in Tawi-Tawi. I'm a physician in Tawi-Tawi, and there's no surgeon. So that certification to operate minor or simple operation should be in Tawi-Tawi only. If I go to Cagayan de Oro, then I should not do that. So it's something in terms of polish, it should be written about task shifting.
Divine, nakamute ka.
Sorry po. Another question po from Sir Jake Brian Cortez. How can we best teach the PFC approach to medical students and residents? Can PFC be adopted to other health profession or medical specialties? Thank you.
By all means. For me, I would, well, although it is something that we crafted in our discipline, but if it for improvement of patient care, why not? Probably there would be some differences in the way we do it because we are trained on some aspects. For example, family oriented care, we know how to help families go through certain stages and helping them attain, the desired outcome that they want. For example, in doing operation or agreeing on operation, we conduct family meeting. So probably in terms of doing it may be different based on your practice. So if the PFC can be done by, for example, midwives within their context, they can use it. I think that is the importance of sharing it to other cadre.
Another question to ulit from Glenn Pono. How do we translate UHC in teaching basic sciences like anatomy, physiology, biochemistry, etc. in medical curriculum?
Okay, so there's a new concept now, the health system science, that would integrate basic sciences to clinical so that there will be a continuum. Although, for example, in the College of Medicine, there's an attempt to integrate. So that's why we have the organ system integration, so that the use of your knowledge on basic sciences can be translated to actual patient condition. And if you probably inject some principles of universal healthcare, discussion about social context, you're using a case scenario and discuss about social context, and that's a very good strategy. You can also use interprofessional education. Let the students practice. For example, doing a biochemistry laboratory. Introduce how to have interprofessional collaboration. Their lab technicians involved in a project or invite probably other health professionals to be part of a certain integrated program, so that the students were experienced talking about a certain basic medical concept with other health professionals.
Okay, so there's another comment from Red. Sabi niya, sana mag-align na din ang mga licensure exams to PHC and UHC because such exams strongly influence curricula. Would you like to comment on that, Lani?
I think it will take some time because right now they're still within the forming stage of the revision of curricula. So there's storming is gone because people are accepting the fact. So they're forced. Even if they're forced, it can be a good thing because they're forced, so they have to read and understand their curricula. So but they're now revising and reorienting it. I think maybe in the future, the full implementation of UHC will be in 2030. And that's the promise of DOH, that everything would be in place. So what we're doing right now is just a preparation of the 2030. Nothing is written or cast in stone right now. So more of modeling, discovering what is applicable to us, even, although I don't want to touch about it, even the financing aspect. It's not the final one. People are just experimenting things or models.
Yeah. Thank you, Lani. And there's another comment from Sir Jake Bryan. Thank you for the validation, ma'am. I firmly believe that the PFC approach can reinforce the teaching of quality in healthcare to students, regardless of health professions. Thank you and more power to you. Yeah, and there's another question from Sir Nino. Should all paramedical courses have the same training for PHC as nursing? As currently, we are all healthcare professionals, but only nursing are well trained in PHC.
Okay, so there's now this month, all cadre, all health professionals, those are involved in regulation, in board examination, they're convening to talk about the common competencies. And they will now try to understand what would be common in terms of approach. And definitely, PHC is a generic. It pertains to all health professionals. And actually, it's a multisectoral. So it can be utilized by all, including especially those who are really engaged in primary care, for example, the midwives. Those are also doing services in the home care, uh, our OTs, PTs, and other health professionals. But we have to impress it. People mistake primary care with primary health care. So we have to correct it and impress what is really primary health care.
Thank you, Lani, again for that reaction. So sabi ni Red, yay, agree with you, Ma'am Lani. In small steps, we will get there. And then there's another one from Search Shan Bondo. Hello, ma'am. For the implementation to be effective, maybe we should look into deploying students or trainees more.
Okay. Okay, so there's a lot of discussion about the deployment, return service obligation. So in the master plan, that's one of the strategies for ensuring enough exposure of our scholars to be serving remote and rural areas. So there's already that return service obligation. But then again, which is a critic to that kind of approach, is that it's very selective. It's open to private, but it's mandatory to government. So again, there's a leeway because, there are cadres or there are HPEs that are more in private institutions. So I think, but, probably if we keep on engaging discussions, because the understanding there is we have to try, because there are a lot of resistance. We tried in the College of Medicine before it was accepted. There are a lot of resistance. So I think slowly but surely, when people are used to it, even the deployment of medical specialists, those who graduated from DOH or government training institutions, uh, before they don't like it. But when there are a lot of discussions about self-fulfillment, they were appreciated, they're able to serve, it's more of beyond them experience. Then slowly it became something that others would want to try. So I always say it's always about goodness and showing the goodness of the profession for other people.
Another question po from Reynaldo Jr. Santamina. Our observation that majority of medical students have the idea that when they graduate, they must do residency training to become specialists. Also, majority of them, even laymen and patients regard the specialists as more knowledgeable or more special. Maybe it is because of their perception that specialized get paid more or they pay specialists more compared to primary care for provider. Even if other countries like US, this is what they have seen. Tama po ba ang observation na to?
Yes, perfect, perfect. Primary care practitioner is always considered as the lowest in the ranks of health professional physicians, for that
Yes.
matter, and they receive the lowest salary. It's not glamorous at all. People are thinking, you're serving the community. You don't have car, you have kalabaw. So, those understanding. But when they try, when when we immerse them to that kind of experience and give them reflective practice, let them talk about patient journey and touch their heart, the humanistic side of being a health professional, then I think you will catch them. And we have tried actually Ateneo for that. I have to drop the name. The university Ateneo have a exposure of their medical students in Northern Samar. There are a lot. Before, they were only 10, and then now they have hundreds of students. This is voluntary, and they have to pay it out of pocket. But Northern Summer is so generous that they provided for foster families. So, you just have to give them the opportunity to discover for themselves, not dictating on them your perception. So, leap of faith, deep dive, and try it.
Another po from Nelson Soriano. We are now educating and re-educating doctors from primary care. How do we also shift the paradigm that health educators, especially sa College of Medicine, they would not be medical specialists? What structures in academics to be changed?
I think, hi, Nikki. So, I think what we need to do is we have to work together. I and the if you have some courses, you start it in your own backyard. You try to show a certain model and share it to other people and invite people to be part of that program and slowly getting them in the how do you call that, in the bandwagon, so that they will join you if you cannot influence the administrators. But I think the administrators are forced, unless they are not very serious with the reorientation. But if it will translate to licensure, I think they will become serious on changing, reorienting, exposures of students more in where patients and people are, than staying in a very hospital centric exposure. Because we're giving them wrong message. Hospital are for sick people. You wait for them there, and that's when you see them. So that's why that pie that I have showed, majority of the population are out there. So they don't receive that care. Mas maganda pang hospital, di ba? So that's why we have to shift that and encourage our colleagues. You cannot influence the administrator.
From Sir Jake Brian Cortez po ulit. Should we develop primary care as clinical specialty?
I don't want to I don't want to give my opinion, but this is not my take. No, I'm not conformist anyway. No, because if you do that, you will create silos. What we want is primary care team that is made up of health professionals with specific skills, not specialization determined. If pediatricians would go to primary care and they learn how to provide womb to womb, why not? If a surgeon would want to do that, because we have one in Eastern Samar who became MHO, had to unlearn being a surgeon. But, of course, I don't want to be self-serving, but trained with us just to be able to unlearn things from previous training. So if you do specialization again, you will take it apart from the whole pie. Okay. So, family physician, we embrace primary care. And we say that we are specializing ourselves towards provision of quality primary care. But not only primary care, there are other competencies of family physicians. Now, if you take that again away and make a primary care specialization, it will defeat the purpose of having a collaborative practice.
There's another question. So, do you think the ladderized program or curriculum for health workers, such as midwives, no, nurses, medical doctors, would be able to contribute to the shift of focus to primary care?
People love ladderized now. So I think because it's hard to finish a program, is that it? Are we having multiple competencies? That's why we just have to choose. I think not all, but having a ladder type program can give an opportunity to those who cannot afford to finish the whole program. An example of this would be the SHS. So although it's a very long program until being a doctor, but if you are just meant to be midwife, then that's enough for you. I we're given an opportunity to train. So that is the value of a ladder type curriculum. But it may not be applicable to all. There are learners who would want fast track. They have to do it full time and finish it on time. So there are learners like that. So it may not be applicable to make it generalized concept.
There's another comment here from Chan Bondok. Agree po, ma'am, in touching the hearts of the students and making them appreciate the beauty of primary care. Then another question, no, comment. Ma'am, I think future medical doctors are willing to go into primary care for as long as their values as doctors can give them appropriate salary and safety. This is my personal reflection. This is from Agnes Segunda Herasmo.
Okay, Agnes. Unfortunately, and fortunately, I think they are trying to revise the devolution concept. The concept is good, but how we implement it is not good. So I think in terms of, for example, provincial and local district hospitals are under the local government. Uh, the Magna Carta for health workers sometimes do not apply depending on availability of budget. Although for those with ERA that are so high, they give the maximum. But for those poor communities, they're being augmented by the national government. So that's the issue. Now, in terms of making it equal to all, you read the master plan, there is an attempt to standardize the salary of health professionals because it's already in the Magna Carta for health workers, the standardization of salaries. But is it enough? Of course, we cannot say it's enough. In terms of safety, I think the DILG should be also be on board. That's why it should be a multi-sectoral approach. That all interventions, those sectors or governments who are responsible in ensuring good implementation like security, education, etc., should be together. DPWH to provide a good road for health workers and patients alike. So it's more of really a whole system development, including social development.
Okay, thank you, Lani, again. And there are other comments. Allow me to read them. For as long as government can give them just salary and safety. And then, yes, there will be an evaluation. The link will be posted in the chat box a little later. And then another comment from Consuelo Pumanes. Decades ago, government hospitals required proof of 2 years of rural service before accepting applicants to residency to encourage provision of services in underserved areas.
Ma'am,
And last question. Sorry, Lani, go ahead. Okay. And there's the, yeah, this is a question from Dr. Coralie Di Macali. Can you talk about longitudinal clerkships?
Ma'am Coralie, yes. Longitudinal exposure in communities. There are a lot of, no, I think that's vertical. Longi is like this. Okay. Ah, it's hard to talk about that because I don't have any experience. But I think the straight internship that we have uh, is similar to that. We never had longitudinal clerkship, except for like in the College of Medicine, ambulatory and inpatient. But if it can be converted, that both primary care and hospital care be introduced so that they have more time to learn and be exposed in different setting, that would be good. I don't have any idea about longitudinal. What I know is a vertical exposure of students to primary care practice. So, which is what we've been doing in the past. Like there are some number of days, COME days, that even first year students will be immersed or will be exposed in rural communities. So I think that is what I know. Ma'am, you were there.
I'm here. So
Yes.
can I just explain? So longitudinal clerkships, the way I understood my readings is taking the students' clerkship not in the hospital under different specialties, no, but instead going to the community, and then as the student experiences that care in the community, he or she will get credited for the usual credits that you get from the from the specialty clinics. So as you see a patient who delivers, then you get an OB credit for that. And as you go through, and they have looked at, in the US, they have looked at the performance of these students compared to those who went through the hospital for their clerkship. And the performance in the USMLE is comparable. So it might be a good thing to take a look at it and see if that such a model can be done, no, in our country. But that means that we will have to have um, mentors and educators already in the field, no,
Yeah.
who serve as good role models for the students while they are rotating in the community.
Yeah,
I
because
don't
what
know
we
if you're
have
ready
is
for that.
straight internships on, for example, in our department. So I think that's what we have. And we have few students, 10 students at a time. Now, if it will be a whole batch, for example, the College of Medicine, that would be 200. And
So,
we
so most
lack preceptors
Yeah, so
who,
most actually start with dual programs. So
yeah,
the track that you want to take, if you want to join this longitudinal clerkship, that's one track. But you can also do the track of having specialists. Kasi we also need specialists, no? So if
yeah.
everybody just does generalist, ang feeling ko, anong mangyayari naman sa more difficult cases, di ba? Na kailangan matignan talaga ng specialist.
I think that's the reason why the DOH is writing about regulation of um, available specialists. So if you have many ophthalmologists, so probably you have to limit the number of entries and you need more nephrologists and you have to add more. So I think, but I don't know if they already have that kind of policy because it's hard to think about it. You have to really have a very good database of all
That's where
practitioners.
informatics is very important, documentation. So, hindi pwedeng mawala yung data collection. Kasi that will guide us as to the need of the society.
Okay, thank you very much again, Lani and Dr. Coralie, for that very good input. Now, there's another one here. One thing that should probably be done is that medical school curriculum must put a lot of emphasis on family, community, and preventive medicine, since it is the field most closely associated with primary care. A lot of our medical students consider family med as a minor subject, so they don't attend such classes. I am a specialist myself, but since I joined the academe, I have readily realized the importance of primary care, especially in third world countries like the Philippines. So that's a comment po from Sir Reynaldo Santamina. Okay, and then there's another comment from Nezar Soriano, clerkship. Ang meron is straight internship. Yeah, I think that was mentioned earlier already. So, are there other questions, comments, reactions? If there's none, I'll turn over so meron pang huli. Divine, would you like to read the comment?
From Sir Glenn po, no? I have observed some family, community, and preventive medicines resident going into subspecialty training in geriatrics, palliative care, toxicology. Is this the acceptable current practice, especially now that we need more family and community-based physicians?
It's hard to answer, but based on, well, it's my opinion. Okay, I think what we observe here in our training program in PGH, we have so much number of months in communities, rural and urban. So our graduates, because we have such exposure, are now going to TTTBs, to MHOs. But there are a set of individuals who would want to go to geriatric, to palliative care, because they will go back to their area of residence and serve in DOH hospitals. We have such experience that the DOH hospital would want them to train. So I don't think we have many graduates who would want to go to palliative, geriatrics, and toxicology. So we have handful. But I think that is changing. I mean, there are a lot of trainers in family medicine now here in the gallery, and they would affirm that their graduates actually are staying in their locality, which is already a breakthrough, because most in the past, if they're trained in PGH, they stay in Manila and they don't want to go home to their province anymore. So I think that consciousness already are sinking in, because we impress to them context of families, context of patients, and their service are needed in their area. So hopefully it will change, because if we will have more strong articulation of primary care, public health, and looking at service provision in the underserved, I think it will change the landscape of distribution of our graduates. I'm hoping for that.
Comment from Ma'am Agnes po. Salamat Ma'am Lani for this multisectoral lecture on primary care concepts. Is there any question po? If not po, we will like we would like to award the certificate of appreciation to our speaker. National Teacher Training Center for the Health Profession, University of the Philippines, Manila, and Corazon Paulino Gonzalez Memorial Foundation Incorporated. Present this certificate of appreciation to Leilani A. Nicodemus, MD, PFP, in her invaluable contribution as speaker during the online monthly seminar on assessing the primary care health professions education given on November 28, 2022, signed by Melflor A. Atienza, MD, MHPed, Professor and Dean, NTTCHP, and Erling A. Sana, PhD, President, CPGMFI. We would like to request everyone to turn on their cameras for our teacher taking. Alvin, please help. No.
Thank you, Dr. Nicodem.
Don't forget po the client satisfaction survey.
Mm. We would like to request everybody to fill out the short client satisfaction survey to help us improve our services. Claire, share this link through chat. See you on our future events po. Thank you very much for joining us. Merry Christmas po.
Thank you, everyone. Thank you, Lani.
Thank you so much po.
Merry.
Yes!
Tapos na.
Salamat po sa lahat.